Good afternoon, everyone, and welcome to this EuroPCR 2021 session entitled Challenges and Opportunities in High-Risk Patients Undergoing TAVI. My name is Marco Valgimigli. I'm working at Cardiocentro in Ticino area in Switzerland, and it's my privilege today to be joined by two distinguished faculty members and friends, among them Peter Nordbeck from Würzburg, Germany, and then Raul Moreno from Madrid, Spain. The objectives of these sessions are to discuss where we stand today in terms of aortic stenosis treatment, namely, of course, TAVI treatment, as well as where we would like to be in the near future. And therefore, we would like to discuss the designing and perhaps even the interpretation of TAVI trials for high-risk patients. We will discuss the timing of TAVI and PCI, but perhaps a discussion will be broader than this. We will discuss if, how, and when to perform PCI in patients undergoing a TAVI procedure with established coronary artery disease. And finally, we will be discussing a very hot topic today, which is the delicate and difficult sweet spot between preventing thrombotic events, both in the coronary arteries as well as beyond, and at the same time mitigating the bleeding risk. Please remember to post your question via the chat. I will be also your chat master today, and we will be very glad to answer all questions or comments that you would like to post to us. So with that said, I would like to call upon the first presentation, which will be given by me, which is indeed, in fact, discussing the designing of TAVI trials for high-risk patients. Importantly, when this video was recorded, namely a few days ago, the results of Atlantis studies were not of public domain. As you may know, the Atlantis studies has been presented a few days ago at ACC, and we will take the opportunity in the Q&A session to address the results and perhaps the clinical implication of this important study. Thank you for watching. Good morning. My name is Marco Valgimigli, and I'm working at Cardiocentro Ticino. It's my privilege today to discuss the topic of designing TAVI trials for high-risk patients. Please have a look at my disclosure. Since the inception of TAVI back in 2002 by Alain Cribier, the TAVI treatment became an option not only for high surgical risk inoperable patients, but nowadays also for intermediate and low surgical risk patients. Now, while these risk categories refer to mortality per se, importantly, non-fatal ischemic and bleeding events followed somehow a similar pattern. Yet, in the so-called low-risk patient population, the rates of these adverse events are roughly 10 times higher than in average patients undergoing PCI. And importantly, both risks do peak at the time of TAVI intervention per se. Similar to stent, also transcatheter heart valves can undergo thrombosis. However, unlike the coronary stent, this event is not prevented by a regimen consisting of aspirin and a P2Y12 inhibitor, but rather by administration of anticoagulation. And today the evidence speaks in favor of both VKA and direct oral anticoagulants. The most updated guidelines that we have informing on the best treatment options in patients undergoing TAVI are dated some years ago, and they in fact still speak about dual antiplatelet therapy. In the European Society of Cardiology guidelines, a DAPT regimen is recommended with a class 2A level of evidence C for 3 to 6 month period, whereas in the American guidelines, the same regimen is advocated for at least 6 months. In Europe, the focus is more on the high-risk patient population in whom a single antiplatelet therapy can be considered, whereas in the United States, the focus is more on patients in whom the bleeding risk is perceived to be low, whereas a BKA in this specific population can be considered as an alternative to DAPT. However, since the release and the publication of these guidelines, two important studies have been presented and published, namely Popular TAVI and the Galileo trial. Let's quickly review this evidence to better understand how the results of these two studies may and perhaps will affect guidelines in the future. The Popular TAVI was a large multi-center European investigation in whom patients with a clinical indication to undergo TAVI without concomitant coronary artery disease and therefore without the need for PCI were actually included in two strata. The stratum 1, which is shown here, focus on patients in whom there is no indication of oral anticoagulation. And the study allocates the patient to either the control regimen consisting of DAPT for 3 months, followed by aspirin monotherapy up to 1 year, or aspirin monotherapy since the very beginning. The patient was powered for a net clinical endpoint and for the overall bleeding complication at 1 year. And in fact, both were in favor of the monotherapy as compared to a dual antiplatelet therapy group. The stratum, second stratum, or if you will, the cohort B of the study focused on the other side of the coin, namely patients whom there was an established indication to oral anticoagulation. In the control arm, this patient received the standard of care treatment consisting of OAC plus clopidogrel, whereas in the experimental arm, only OAC monotherapy was implemented, and OAC was any type of oral anticoagulant that was in place before the procedure. Again, the study was powered mainly for bleeding endpoints, and in fact, this study did also show a much lower bleeding risk in patients whom a monotherapy regimen was implemented as compared to a dual antithrombotic therapy regimen. Now, this study is an important one, of course, if anything, because it's one of the first and one of the few studies we have in this space. However, it's very important to focus on very important limitation of the study, such as the open label design, but perhaps even more importantly, the fact that bleeding occurring during TAVI at the time of the index procedure were, for whatever reason, defined as non-procedure related. And in fact, those bleeding events drove almost entirely the bleeding risk at 1 year follow-up. Also importantly, as I was referring to before, the study was mainly powered for bleeding endpoints. And in fact, despite a formal non-inferiority claim for the ischemic events, the non-inferiority margins were extremely high at 7.5%, which basically makes the study very unreliable to inform the community whether by dropping one antithrombotic regimen in these two study groups would really not be associated to any extra ischemic risk. Very recently, based on the result of this study, a ESC consensus document was actually released. This is a consensus document, not a guideline document, but yet it's very informative. And basically, as you see here, in patients in whom a recent coronary stenting took place, as these patients were not part of the investigation, nothing changed. A dual therapy regimen is implemented and recommended, whereas in patients in whom that did not happen, a monotherapy approach, either with oral anticoagulation or a single antiplatelet therapy, is now potentially recommended. Now, today, we need also to factor in the important findings coming from the Galileo study, which actually focus on patients in whom there was no baseline indication to oral anticoagulation and randomized them to a DPI consisting of aspirin and rivaroxaban given at 10 milligrams once a day, followed by rivaroxaban monotherapy after 3 months, versus a DAPT regimen for 3 months, followed by aspirin monotherapy subsequently later on. The primary outcome was a pure ischemic primary outcome, defined as the composite of death from any cause, thromboembolic events, including any stroke, MI, symptomatic valve thrombosis, and systemic embolic events, DVT or PE. Now, the study was in fact prematurely stopped by the executive committee, which followed the suggestion from the DSMB because of a potential harm connected and associated to experimental therapy, whereas actually only 42% of the overall 440 planned events actually occurred in the study. The primary efficacy endpoint was significantly in disfavor of rivaroxaban. There was a nominally significant higher mortality rate in the rivaroxaban arm, which was almost entirely driven by non-cardiovascular events. And importantly, there was a signal that the bleeding risk was numerically high in patients receiving rivaroxaban. Now, an important consideration is the fact that at an on-treatment analysis, this excess of mortality was not apparent anymore, speaking for the fact that these non-cardiovascular fatal events mainly happened remotely from either rivaroxaban or the APT intake, which puzzles a bit the interpretation of the study. However, the study did show in a very clear manner that anticoagulation did work with respect to the prevention of valve thrombosis. As you see here, reduced leaflet motion went from 11% in the Antiplatelet regimen down to 2% in patients receiving rivaroxaban. An important study which will recently become to fruition is envisaged TAVI AF. It focuses on patients who have an indication to oral anticoagulation because of atrial fibrillation undergoing TAVI. They were randomized to a doxaban-based treatment regimen or a VKA-based treatment regimen with or without antiplatelet therapy in both treatment groups as per standard of care. The study is very well powered with two co-primary endpoints, an ACE endpoint and a bleeding pure endpoint. Both of them will be tested as a non-inferiority basis and then, if met, as superiority as well. Another important study which is coming to our attention soon is the Atlantis investigation. This is again a large multi-center European study involving roughly 1,500 patients undergoing successful TAVI procedure. Patients are stratified based on whether there is or there is not an indication to oral anticoagulation into stratum 1 or stratum 2 respectively, and then they will be exposed to an experimental treatment consisting of apixaban 5 milligram BID in the experimental arm consistently across the strata, or VKA in stratum 1, or DAPT or SAPT in stratum 2. What makes this study a bit difficult to be interpreted is the very large primary endpoint, which is a combination of ischemic and bleeding events nominally, so a sort of a net adverse clinical endpoint, but also the fact that the study is a superiority design, whereas in my humble opinion, there is a superiority in fact hypothesis in stratum 2, but perhaps more a non-inferiority hypothesis in stratum 1, where two anticoagulants are being compared. So in conclusion, while awaiting for the results of Atlantis and envisaged TAVI AF trials, the role of DAPT after TAVI in patients without CAD, PCI and no OAC indication has been indeed questions on the basis of the bleeding risk in favor of SAPT, namely aspirin. The role of DAPT after TAVI in patients without CAD, PCI, and a formal OA indication has also been questioned on the basis of the bleeding risk in favor of an OAC monotherapy. At the same time, the antithrombin hypothesis has been questioned by the Galileo trial on the basis of a higher mortality risk, mainly non-cardiovascular, not apparently explained by the bleeding risk and not directly connected with drug intake. Thank you very much for your kind attention.
Hi, Marco. Thank you very much for this excellent presentation. I don't know if there is any question from the audience in the chat.
Yes, thank you, Raul. There are actually many questions. Some of them will be addressed in the next slots, so I would refrain from asking those questions right now, but of course we will later. One question which is really specific to this section is whether we can discuss openly what is our standard antithrombotic regimen after TAVI in our patient today, based on the evidence that has been discussed right now. So why did you start, Raul, yourself? What do you do in Madrid with your TAVI patients?
Well, in our TAVI patients, that don't have indication for oral anticoagulation, I think the results of the popular TAVI are being implemented in some centers. In some centers still are indicating double antiplatelet therapy, but more and more patients are receiving single antiplatelet therapy, despite not being implemented in the current guidelines. And in patients on atrial fibrillation, despite the absence of evidence, I think that more and more patients are receiving direct anticoagulation instead of vitamin K antagonist.
So then to summarize, you're dropping already a DAPT regimen in patient without PCI?
Yep, I think, although not officially, I think more and more colleagues are indicating only one antiplatelet therapy instead of the two antiplatelet therapy that are theoretically indicated still, according to the current guidelines.
And which one you select, aspirin or clopidogrel?
Aspirin. In my case, aspirin in most cases.
Wonderful. Peter, what do you do in Germany with your TAVI patients?
Yeah, actually, I think Raul very, very nicely concluded already what I think most of the centers at the moment will probably think about and do. Actually, we used to have dual antiplatelet therapy as standard of care, and more actually switching, even though I have to say that many of our patients, I think in all the centers already have an indication for dual antiplatelets. So in those patients, so this question is maybe not on the forefront. The other question, I think, which is important, is of course what to do with those who have an indication for actually oral anticoagulation, particularly the patients with atrial fibrillation, of course. And I think in those patients, we're still not so sure how to handle these. Actually, we most of the time will stick to the medication they had before the intervention.
Well, I have a very similar practice. So without further hesitation, there are many other questions which are being posed. So one colleague is noting that the thrombosis of the valve could be related to valve durability, of course. But many are asking your interpretation of the Atlantis studies. So the Atlantis was released a few days ago. What's your reaction to the results? Would your practice change? And if so, in which direction?
In my case, I think that the Atlantis trial has shown, from my point of view, disappointing results, because I think most of us were expecting less events in patients receiving apixaban. I think that the other point of view is that we can prescribe direct anticoagulation instead of vitamin K antagonist, because the important thing I think is that we didn't have any evidence about the use of direct anticoagulation instead of vitamin K antagonist during the first months after TAVI. Theoretically, we should prescribe vitamin K antagonist at least for the first 3 months after TAVI. We are now expecting the envisaged trial, as you have explained, Marco, and the envisaged trial has included only patients on atrial fibrillation, so 1,400 patients. I think this is a higher number of patients in comparison with apixaban. If the apixaban trial includes only atrial fibrillation patients, we have to expect the results of the envisaged trial. But I think that now we already have evidence that allow us to prescribe direct anticoagulant drugs instead of vitamin K antagonist, and we didn't have any evidence up to date.
That is a good point. I have to say that without evidence, as you, Raul, very correctly pointed out, we were doing what Peter was suggesting before, namely not to switch the type of anticoagulation. The majority of these patients already carry an AFib burden before TAVI, and they would basically continue with the same anticoagulant. Perhaps an open question is whether you would feel free to start a direct oral anticoagulation in patient developing AFib after TAVI, and actually that was our practice even before evidence was there. But now the Atlantis is providing some evidence. Yet, and that I'm referring now to Peter for understanding his personal interpretation of the Atlantis study, we need to admit that the study was perhaps powered as a whole, but if you take the OAC stratum out of the equation, we are speaking about a relatively limited number of patients in whom the power is clearly lacking. So the study is not conclusive in that respect.
I absolutely agree. I think that's an important issue, that because of the two arms or the four arms, it's the actually the meaning of the current results is limited. And I think there is one second point which we need to take into account, I think, which is actually the timeline. I think we more and more have many TAVI patients who get younger and will have the TAVI for their valves for many years. And I think when looking at some of the results we have today, especially, of course, from Galileo, which was stopped early, those results might change when we look at longer time frames, maybe 5 years or something. So then maybe this might be, the vision might be changing. So I think for now, that's not really conclusive evidence.
I agree, Peter. Thank you so much. The time is running, so it's time to hear your talk, which is entitled Timing of TAVI and PCI, but in fact is much more than this. So please have a look.
So good evening, dear colleagues, and thank you very much to the organizers for inviting me to this exciting and important session on to speak on timing of TAVI and PCI. Let's a quick look at the disclosures. So why is this topic exciting and important? I think that's pretty obvious. We have largely rising TAVI numbers over the last years, with many thousand patients treated every year. And at the same time, many of our patients we are treating have coronary artery disease, with the data from studies reporting prevalence of around 40 to 80% in the TAVI candidates. And for example, if we look even in the intermediate care groups, then prevalence has been reported as high as 2/3 of patients. At the same time, myocardial infarction and PCI post-TAVI are a considerable problem we encounter in our patients, with reported numbers in several studies around 5% at 1 or 2 years' time. That's the facts on prevalence. The other facts we are facing are that coronary access post-TAVI might be severely limited. We have a poor prognosis of patients with TAVI who need to undergo acute revascularization. And third, we have actually little knowledge on the positive effects of revascularization in octogenarians, which are the majority of our patients. So when we look at the data we have today, then it's can actually acknowledge that there is a number of publications with actually still a rising number, and also a couple of algorithms have been proposed, such as the one from Kao et al. We see on the slide. And however, we have to acknowledge as well that this is mainly until then based on observational data, and the true evidence we currently have is really small. I think most of the centers, including our center, actually handle the patients similar. We are used to handle the patients who undergo conventional surgical aortic valve replacement, and this is also matches the considerations and suggestions from, for example, the ACC Appropriate Use Criteria given on this slide, who actually largely favor PCI early in the patients who have coronary artery disease and undergo TAVI. We have several observational trials, like I mentioned, who looked at coronary artery disease and PCI in the context of TAVI, and most of them compared whether it might be more favorable to do the TAVI alone or the TAVI together with the PCI, either in the same procedure or before the TAVI. And for example, looking at this meta-analysis from a number of smaller studies, observational studies. Actually, it's a busy slide, so don't want to go into detail, but I think what you can easily see is that actually there does not seem to be a large difference when comparing the outcome of either a prior PCI or TAVI alone. This paper is also focused on the differences which might arise from concomitant or a priori PCI. I think there are a couple of considerations which might account for positive or negative effects. In this paper with actually small numbers, and again, that's observational data, the author found no statistical difference between both strategies. However, I think we also have to acknowledge that actually in a large number of cases, concomitant PCI with TAVI will be problematic since there are many aspects, such as also, for example, reimbursement, which might be a hindrance for a very comprehensive approach in one procedure. A number of smaller trials and publications looking at mainly observational data, again, in either a single center or also multi-center observations, have looked at the severity of coronary artery disease, whether this mightn't be a major factor when deciding whether or not patients should undergo PCI prior to TAVI. And this is one of the publications where actually 3 centers combined their data, and the authors actually reported that when they looked at the outcome of patients who had any coronary artery disease, there was no difference in the outcome as compared to those who were free of coronary artery disease. But they found a difference when they looked at severity using the syntax score, so with a syntax score of greater than 22, or also a high residual syntax score in the patients. The authors found considerably poorer prognosis, which was also highly statistically significant in this publication. There's a second publication which used a very similar approach and also looked at disease, coronary artery disease severity. This approach was a bit different since the authors used CORLAB to grade coronary artery disease severity, and actually the authors and this investigation did not find a significant impact of coronary artery disease severity in contrast to the one. So in advance to in addition to the data from observational trials, we also currently have data from one randomized control trial, the activation trial, even though this is not yet fully published. We've seen the first data last year. And actually in this trial where the authors randomized patients, the mean age of 83 years, with aortic stenosis, of course, and coronary artery disease to either PCI or no PCI. The authors found no difference in the risk of death or rehospitalization 1 year post-TAVI, even though they did find a considerable amount of higher bleeding in the patients who underwent PCI. I think when it comes to the grading of coronary artery disease severity, it's important to acknowledge that many of the tools we use in cardiology today to decide whether or not patients should be treated by PCI are really not validated in TAVI today. So this is an example of a paper focusing on FFR and IFR in aortic valve stenosis patients, and I don't want to go to deep detail here, but it's shown very nicely that the FFR in many cases underestimates the severity of the stenosis, and if at all, we should better use the IFR to decide whether or not a stenosis might really be cause an issue in our TAVI patients. A major issue, of course, is coronary access. A couple of publications have focused on access in different valve types. I think one major issue we really need to focus on maybe more in the future with younger patients and also patients getting older is the alignment of the commissures to the coronary artery, especially the left coronary artery, and actually also a couple of proposals have been there in the last month and years, how to maybe better align the commissures through only small changes in our implantation techniques. The device type, of course, is something which should take into consideration, first of all, prior TAVI, but also after TAVI. We have to acknowledge that not only the device itself might cause problems, but also some issues such as bulky calcifications shown here might be problematic. So we should aim at foreseeing such problems also by choosing the device type, and maybe avoid too much oversizing of the device in order to allow a good access to the coronaries for the future. I think a couple of publications have nicely shown, and also from clinical practice, we know that usually still coronary angiography and also PCI post-TAVI is possible and doable. In the vast majority of cases, we do succeed if needed. There are a couple of publications who give recommendations how to maybe best succeed, and just one comment that there also is now an app which might be used to guide physicians in specific situations to use the right techniques to access the coronaries. Last but not least, one issue which I think will become extremely important in the next month and years is also the antiplatelet and anticoagulation regimen we have post-TAVI. For example, looking at the popular TAVI trial, I think we have learned that not always more anticoagulation or dual antiplatelet therapy is better, but I think this will be a focus of the next talk. Additional considerations. I think not only the patients are changing in a way that we have more low-risk patients and younger patients, but also I think when we look at those observational and also trial data, we have to acknowledge that there might be different outcomes if you look at longer time spans. And this also accounts to the rising numbers of repeat valve-in-valve procedures we are seeing even today. With that, I would like to sum up. I think management of PCI in TAVI is really a still open issue, with the management mainly based on observational evidence. Key considerations today include the severity of coronary artery disease, the device type and implantation technique, with a main focus, of course, on coronary access for the future. Anticoagulation therapy is important, and a couple of randomized trials are already ongoing, and I think we really need those to better certify our strategies for the future. Thank you.
Thank you very much, Peter, for this very extensive and comprehensive talk. So you escape the answer, but the audience here is pushing you to give a clear answer. When do you do PCI in patients in whom TAVI is scheduled? Before, during, or after? And Raul, prepare yourself, because I will ask you the same question.
So actually, I think that is the key issue. So usually I would do the PCI before. In all those cases where the symptoms could be caused by, when more or less, I think the symptoms are in a major part maybe caused by the coronary artery disease, and in the cases where left main or really a major vessel is involved. And I would not do the PCI if that's maybe a smaller vessel, or also I think age is important. I actually avoid to do the PCI after the TAVI.
Okay, that's a clear answer. So then question back to you. You mentioned left main. You are not worried that you could have hemodynamic instability during left main intervention, and in patient with aortic stenosis that would call for some trouble?
Yeah, I think it really is an open issue. So I had just 2 weeks ago, I had one case where we had like a 40% left main stenosis in an older patient, and in the end we decided not to do the intervention before, and then we had really the left main closed during the intervention. It turned out nicely in the end. Everything after stenting of the left main. Directly after TAVI, but I think that's then really a complicated issue, and you have all this stressful stuff. So usually I would try to do the left main stenting before.
And Raul, what's your practice in Madrid?
Yes, I will try to answer very shortly. In most of the patients, we perform the PCI before the TAVI, but in some patients in which the procedure could have a very high risk, we have treated them after the TAVI. And we usually perform PCI in patients with proximal or mid-segment severe stenosis, but in most of the cases before the TAVI.
Okay, just then to confuse the audience, I was trained in doing TAVI intervention in Bern, in Switzerland, and actually there is one rule in Bern that the PCI, if it has to happen after TAVI. So you see that every place is completely different, and it's entirely true that we don't have clear guidance. We are running a bit late, but I will cut my conclusion statement to be able to discuss perhaps some technicalities on how to approach a PCI in a patient who has received a TAVI. So Raul, Peter, based on your experience, which guiding selection would you go for, first of all, and whether the type of TAVI which has been implanted would actually drive your decision making to do PCI before and after. Namely, the presence of CED that could be treated after TAVI would drive you towards a TAVI stent type, TAVI type more than another one, or does not matter?
In my case, in the few cases in which the decision of the PCI has been deferred after the PCI, after the TAVI, we have used devices in which the frame is very short and theoretically performing a complex PCI is easier.
Okay. I like your very political approach not to name any valve. I like that. And Peter, what's your approach?
Yeah, I also like the balloon expandable XAS or valve type, and for the second part, if I have to do an intervention which is not so rare, actually we have a couple of patients who maybe some month or years afterwards need an intervention. So from my experience, it works well, specifically with a balloon expandable type. And I usually would go for the Judkins, and in most of the cases, it's not a big issue actually.
That is true. I'm used to do PCI after TAVI, and I have to say, once you basically adapt a bit the technique, you take shorter catheter. If you go for a BU or a Judkins left, I think you can manage in 99% of the cases. Sorry, I need to cut the discussion because time is running, and it's my privilege now to call upon you, Raul, to discuss low surgical risk does not equal low bleeding and thrombotic risk, which will allow us to go back to the antithrombotic topic.
Hello, I would like to thank for this very kind invitation. The title of this presentation is Large Surgical Risk Not Equal to Low Bleeding and Thrombotic Risk. These are my conflicts of interest. Since the development of TAVI, clinical evidence of this therapy has been constructed following an exemplary model, beginning with patients ready for surgery, followed by high-risk patients and intermediate risk patients. The last evidence was obtained in patients at low surgical risk, and this is very important because the majority of patients with aortic stenosis are at low surgical risk. Two randomized trials have demonstrated that TAVI is not only a valid alternative to surgery, but also offers some very important advantages or clinical advantages over surgery. In the Partner 3 trial, TAVI met not only not inferiority in comparison with TAVI, but in comparison with surgery, but also superiority. Moreover, in these trials, TAVI was associated with a very important reduction in the rates of severe complications such as stroke, acute kidney disease, arrhythmia, and severe bleeding. So we can consider now that TAVI is the best treatment for most patients with severe aortic stenosis at low surgical risk. And the questions that now are raised are low-risk patients also at low risk of bleedings and stroke? What is the risk of these complications in patients at low risk? And should antithrombotic therapy be different in patients undergoing TAVI and low surgical risk? Surgical risk is clearly related with mortality after TAVI, and this has been clearly demonstrated in many studies. This figure, for example, shows how long-term survival in patients at low surgical risk is clearly higher than those at intermediate in risk and much higher than in those at low surgical risk. However, the relationship between surgical risk and other complications has not been always very clear. In this study, for example, the risk of bleeding was not related with the surgical risk, and the risk of stroke was higher in patients at higher surgical risk, but was similar in patients at intermediate and low surgical risk. In this case, in the case of stroke, in the Partner 3 trial and the Corval randomized trials, we have seen that the risk of this complication is lower as the surgical risk is decreased. In the case of the Partner trials, the rate of stroke was similar in patients at high and intermediate surgical risk, but it was much lower in patients at low surgical risk. And in the case of CoreValve trials, there is a more clear relationship between the surgical risk and the risk of stroke. When evaluating the risk of stroke after TAVI, it is very important to consider that this event may occur at every time points. In this figure from the observant trial, from the observant registry, we can see how the incidence of a stroke increases almost constantly during the 5 years follow-up. And the clear implication is that the stroke prevention in patients that have been treated with TAVI is a key aspect in the management of these patients during the entire follow-up of these patients. When we observe that what occurred in the PARTNER 3 trial, we can see how the incidence of stroke in the TAVI patients was significantly lower in patients treated with TAVI, 1.2% versus 3.3%. But from the first to the second year, the rate of stroke in patients treated with TAVI was 1.2%. And because of that, the rate of stroke was not significantly different between patients allocated to TAVI and patients allocated to surgery. Obviously, the risk of stroke in patients at low surgical risk is especially high among patients with atrial fibrillation. And for example, in this slide coming from the PARTNER 3 trial, we can see how at 2 years, the risk of stroke in patients with atrial fibrillation was almost 5%. And that was 2 times higher in comparison with the risk of stroke in patients without atrial fibrillation. And the question is now, how frequent is atrial fibrillation in patients treated with TAVI at low surgical risk? The prevalence of atrial fibrillation in the PARTNER 3 trial was 15.7%, and the prevalence of prior atrial fibrillation in the EVOLUTE low risk trial was 15.5%, and an additional 5% of the patients and 7.7% of the patients had a new onset atrial fibrillation after the TAVI. So more than 1 out of 5 patients at low surgical risk undergoing TAVI has either prior or new onset atrial fibrillation. And this frequency is higher even in patients not included in randomized trials, but included in registries, in real-life patients. For example, in the Ocean TAVI registry, we can see how more than 80% of the patients had a previous atrial fibrillation before the TAVI. And we can see on the right the prevalence of prior stroke. We can see how the rate of previous stroke in this registry was not related, significantly related with the risk and with the surgical risk of the patients included. So the risk of stroke is lower in patients at low surgical risk, but it increases during follow-up. And among patients at low surgical risk, the risk of stroke is higher in real-life patients than in randomized trials. Patients with atrial fibrillation, that are more than 1 out of 5 patients, comprises a high-risk subset of patients. And because of all that, preventing a stroke is of capital importance also in patients at low surgical risk, especially in patients that also have atrial fibrillation. And what about the risk of bleeding? Randomized trials have shown that the risk of major bleeding is also related with the risk of with the surgical risk. For example, in the Edwards trials, we can see that the risk of major bleeding was 3.6% in patients in these trials, and in patients at low surgical risk in the CoreValve trials, there was also a relationship, and the risk in low risk patients was 3.2%. But again, in patients included in the real life, so in patients not included in randomized trials, the risk of bleeding is much higher. For example, in this study, the risk of major bleeding was 7.7%. That is 2 times higher in comparison with the risk of bleeding in randomized trials. This is because we know that the risk, the surgical risk includes some aspects that are not always similar to the risk that estimate the risk of bleeding. Here you can see the characteristics that are included in the risk of bleeding, and there are many characteristics such as the prior surgery, critical situation, lung disease, etc., that are included in the surgical risk scores, but not in the bleeding scores. And we can see also that even in patients included in randomized trials in the partner 3 and the evaluable risk, characteristics of the patients are very typical of high bleeding risk patients. The mean age was about 75-year-old. There was a high rate of prior stroke, a very high risk of previous hypertension, peripheral artery disease, diabetes, and of course, most of the patients had a heart failure, and all of these factors are related with the risk of bleeding after TAVI and after procedures in general. Also, it is important to take into consideration that the risk of bleeding after TAVI not only occurs in the perioperative period, but during all the follow-up of the patients, this risk is always present. And because of this, the bleeding prevention is a key aspect of management of patients after TAVI during the entire patient follow-up. Of course, it is very important not only the bleeding that occurs in the perioperative period, but also the risk of late bleedings. For example, in this study, with more than 2,400 patients included in the partner 3 trials that were alive at 30 days, the risk of late bleeding, that is the risk of major bleeding that occurred more than 30 days after the procedure, was 5.9%, and this risk was 8.6% in patients that have atrial fibrillation. An important thing is that this risk was not related with the surgical risk. This late major bleeding had a tremendous clinical impact because these patients had a significantly higher risk of death and also a significantly higher risk of major stroke. It is a very high-risk group of patients, the patients that had late bleeding and also had an atrial fibrillation. You can see how the risk of death in these patients was about 50% at 1 year. So because of all that, preventing a stroke and preventing major bleeding is very, very important in patients undergoing TAVI, even in those patients at low surgical risk, especially in those with atrial fibrillation. Because of that, the NOAC trials in atrial fibrillation patients undergoing TAVI are very important. There are 3 trials that have evaluated or are evaluating NOACs in patients undergoing TAVI. The Galileo, we know that this trial was performed in patients without indication of anticoagulation. The Apixaban has included patients with and without indications of atrial fibrillation, and the Envisage trial is the only trial that have studied NOACs, in this case, edoxaban, only in patients with atrial fibrillation undergoing TAVI. Because of that, the Envisage trial is the most important trial evaluating NOACs after TAVI in patients that have atrial fibrillation. This study has concluded now the follow-up, and the results will be presented very soon. Finally, we have to consider also what is the issue of valve thrombosis in patients undergoing TAVI, and the risk of valve thrombosis is also important in patients at low surgical risk. If we can see what was found in patients included in the partner 3 trial, we can see how the risk of valve thrombosis was 1% versus 0.2% in patients undergoing TAVI and surgery, respectively. And from the first to the second year, this risk was 1.6% and 0.5%, respectively. And because of that, the risk of 2 years was significantly higher, 2.6% in patients undergoing TAVI in comparison with patients undergoing surgery. It could be that this risk is maybe clearly related with the type of device, because the supraannular devices have much lower risk of valve thrombosis, and in the partner 3 trial, an intraannular device was used. Of course, preventing leaflet thrombosis is a special point to be considered in patients undergoing TAVI. There are some trials that are evaluating this issue, and a sub-study from the Galileo trial demonstrated that rivaroxaban reduced this risk. But in the Galileo trial, we know that TAVI treated with anticoagulation was associated with higher mortality and higher risk of bleedings. The question is if the patients at low surgical risk could be different because of having a lower risk of bleeding. This has been studied in this small trial in which the risk of thrombotic events in the valve was lower in patients receiving warfarin in association with aspirin. Here, we didn't see significant differences in the risk of bleeding, but this study is very small. So I think that we can conclude that very soon patients at low surgical risk will comprise the majority of patients undergoing TAVI. These patients have lower risk of bleeding and stroke than patients at higher surgical risk, but are still at high risk of these complications. Real-life patients have higher risk of bleeding and thrombotic events than those included in randomized trials. And finally, balancing bleeding and stroke prevention is still crucial in patients that have undergone TAVI, even in those at low surgical risk. Thank you very much for your attention.
Raul, unfortunately, we have run out of time, so we don't have much time for the discussion, but I think your conclusive slide was very clear. Low surgical risk does not mean low risk of ischemic and bleeding endpoint, but thrombosis is very relatively frequent, and for the time being, we don't have a good treatment both for the valve and for the patients. With that said, I would like to thank you both for having been great speakers and for the audience for watching. Thank you, and continue joining EuroPCR 2021.